Welcome everybody to the webinar, The Flu Ends With You, Pneumonia and Influenza in New Mexico. I'm just going to go over a little bit of housekeeping for the webinar. If you have not already, please take a moment to sign in by entering your first and last name and organization into the chat. And if you are joining in groups, please be sure to enter all the names. We are recording this Sept webinar. All the lines except the presenter will be muted throughout the presentation. But we invite you to use the chat feature to submit your questions. Your feedback and participation is greatly appreciated, and we'll try to answer as many questions as we can at the end. When the recording and the slides become available, we'll send you information on how to access the webinar. CME application information will be entered into the chat box and will be included at the end of the presentation. This activity has been planned and implemented in accordance with the essential areas and policies of the New Mexico Medical Society through the joint partnership or sponsorship of CoMagin Health, formerly Health Insight New Mexico, the New Mexico Department of Health, and the New Mexico Immunization Coalition. CoMagin Health is accredited by the New Mexico Medical Society to provide continuing medical education units for physicians. CoMagin Health designates this live event for a maximum of 1.0 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Just a couple of disclosure statements. In compliance with the ACCME, New Mexico Medical Society standards for commercial support of CME, none of the speakers have any relevant financial relationships to disclose. In addition, in compliance with the standards, none of the planning committee have any relevant financial relationships to disclose. I'd like to now introduce our two speakers. The first speaker will be Chelsea McMullen. Ms. McMullen serves as the Respiratory Disease Surveillance Coordinator at the New Mexico Department of Health. She began at the Department of Health as a cross-cutting surveillance officer, focusing largely on the lab-confirmed influenza-associated hospitalization surveillance network, or FluSurv NET, including medical chart reviews, data analysis, and laboratory audits. As the Respiratory Disease Surveillance Coordinator, she oversees FluSurv NET as well as the Influenza-like Illness Outpatient Surveillance Network, or ILI NET. Recently, Ms. McMullen presented at the New Mexico Department of Health Influenza Surveillance System and the past two influenza seasons at the New Mexico Department of Health Quarterly Epidemiology Meeting, and on influenza outbreak response in long-term care facilities at the New Mexico Healthcare Association Conference in August of 2019. Ms. McMullen received her Master of Science in Global Health from Duke University, where she specialized in zoonotic disease epidemiology and global health policy. She completed her fieldwork in the Democratic Republic of Congo, where she analyzed the transmission dynamics of human monkeypox. Before joining New Mexico Department of Health, Chelsea worked with an international consortium based in the United Kingdom in the coordination of research during international disease outbreaks. Our second speaker will be Emma Stanislawski. Ms. Stanislawski is a respiratory infection surveillance epidemiologist with the New Mexico Department of Health. Her responsibilities include influenza monitoring, surveillance, and advising, and she is responsible for the weekly influenza surveillance report that is published throughout the flu season. In March of 2019, she presented on nosocomial influenza infection at the 23rd Annual Association for Professionals in Infection Control and Epidemiology meeting in Albuquerque. Prior to accepting her current position, Ms. Stanislawski was a vaccine preventable disease epidemiologist with the Maryland Department of Health, where she created and conducted trainings for public health nurses and other health professionals on diseases such as hepatitis A, pertussis, measles, and acute flaccid myelitis. Ms. Stanislawski received her Master's of Public Health degree with a concentration in epidemiology from the Colorado School of Public Health and her Bachelor of Science in Biology from the University of New Mexico. She's also certified in public health through the National Board of Public Health Examiners. And now I'm going to turn it over to Chelsea McMullen.
Good afternoon, this is Chelsea, and today we will be talking to you about the background and epidemiology of influenza and pneumonia in New Mexico and the United States. We're going to talk about our influenza surveillance networks and how New Mexico healthcare providers feed into those networks and reflect the impact of flu and pneumonia in our population and special populations. And then Emma will be talking to you about nosocomial transmission in the context of annual flu burden, and she will review treatment, prevention, and control strategies, including new ACIP vaccination guidance. Moving on to background. There are a few different types of influenza. Influenza A and B are the main contributors to seasonal epidemics. We do have influenza C, which causes a mild respiratory illness, but does not contribute to our seasonal epidemics. Influenza A has two different types of surface proteins, hemagglutinin, or HA, and neuraminidase, or NA, and there are many different types of those surface antigens, surface proteins that can combine to cause different subtypes of influenza A. Influenza A infects many species, most notably humans, pigs, and birds. It undergoes antigenic drift yearly, which causes small changes in the virus and contributes to the need for a new vaccine every year. It can also undergo antigenic shifts, which are bigger changes which cause novel influenza pandemics, or potentially causes those pandemics. Influenza B has two different lineages, Victoria and Yamagata, and it only experiences the antigenic drift, so it does not contribute to any type of pandemic. So going into a little bit more detail about antigenic drift versus shift, like I said, these viruses undergo antigenic drift each year. These are small changes that happen continuously as viruses replicate over time. They usually share the same antigenic properties, but are distinctly antigenically different, which contributes to the need to develop new vaccine formulations each year for seasonal flu. Shifts occur when there are major changes in influenza A viruses. So it occurs when new hemagglutinin or neuraminidase combine to create a novel influenza virus. And most people will not have immunity to these new viruses, which makes them especially dangerous. Like I said, the surface proteins on influenza A viruses are hemagglutinin and neuraminidase, and you can see an image of the virus on the right. 3 out of our 6 licensed influenza antiviral medications are neuraminidase inhibitors. And most common influenza A subtypes that we see in seasonal epidemics are H3N2 and H1N1. These influenza A subtypes cause the majority of cases in the most recent flu season in 2018 and 19. Like I said, influenza A can infect many different species. Most notably are poultry or avian bird species and pigs or swine. And those antigenic shift occurrences that happen are usually happening when different species of animals are kept in close proximity to each other, in which case viruses have the ability to interact and exchange genetic information to create those novel influenza viruses. Of note, we have H5N1 and H7N9, and these subtypes are on the Center for Disease Control's list, as well as the World Health Organization's list of flu viruses that are most likely to cause a novel influenza pandemic if they develop the ability to more easily transmit between humans. Right now, they're not very capable of sustaining transmission between humans, and the likelihood is low that they will, but they are always on the radar of those big organizations that monitor novel influenza. Right now, H3N2 is the most common circulating strain in the Southern Hemisphere. Their season is opposite to ours, so their season is just ending as ours is beginning. So influenza causes illness by replicating in the epithelial cells throughout the respiratory tract. It infects and destroys cells mainly in our upper respiratory tract, but in severe cases can also infect the lungs and other parts of the body. It causes redness and mucus discharge. That's how you see sneezing and coughing. Also, the immune response to influenza infection can cause inflammation, fever, and chills. When influenza is a cause of death, often it's because it has reached the lungs and can cause viral pneumonia. It can also make you more susceptible to bacterial pneumonia. It can also lead to pulmonary hemorrhage and respiratory failure. The virus can reach the heart, causing it to be unable to pump blood well enough on its own. Your immune system can also overreact and cause a cytokine storm, which overwhelms the body with immune cells that can attack both infected and healthy cells. This is common when young, healthy adults die of flu. I'm sure you all are aware that there was a very severe pandemic in 1918. This killed about 50 million people and infected a third of the world's population. And it was caused by an H1N1 strain. And our modern day strains do descend from this 1918 pandemic strain. And you can see the impact, that deep dip around 1918 was because there was a high number of deaths in young adults. And it actually lowered our nation's life expectancy in 1918. We also had a pandemic in 2009. That was our most recent pandemic. And this one was very different from the 1918 pandemic. It had very low severity but high transmission. And since then, this H1N1 pandemic strain has replaced the previously circulating H1N1 strain. So now whenever we see H1N1, it is the same virus that caused that novel pandemic in 2009. Severity varies across seasons. It's different every year, but the estimated ranges are as follows. And you can see those ranges of cases, hospitalizations, and deaths is very wide. So flu seasons can range from low severity to high severity. And just to emphasize that, this is a graph of transmissibility on the left and clinical severity on the bottom. And you can see the 1918 pandemic up in the top right-hand corner had very high severity and very high transmissibility. Whereas the 2009 pandemic is over on your left. It was very low on the severity scale, but about mid-range in the transmissibility scale. There are a couple other pandemics included in this graph, as well as a few more recent influenza seasonal seasons. So you can see 2017-18, which is pretty much in the middle of the graph, was mid-range for severity and also mid-range for transmissibility. So it actually was more severe than the pandemic we saw in 2009. And this just goes to show there is a large range of severity and transmissibility year to year. Moving on to pneumonia. Pneumonia is a lung infection that can be caused by viruses, bacteria, or fungi. Influenza is the most common viral cause, but it can also make you more susceptible to a bacterial infection. The most common bacterial cause is Streptococcus pneumoniae, also called pneumococcus. We also call it strep pneumo. Community-acquired pneumonia and influenza together are the seventh leading cause of death in the United States. And over 900,000 episodes of a community-acquired pneumonia occur in adults over the age of 65 each year in the US. So it is a significant contributor to burden of disease in the US and worldwide. Like I said, pneumococcal pneumonia is caused by strep pneumo. Strep pneumo can cause other manifestations of disease, such as a more mild ear or sinus infection, but it can also cause very severe disease, such as meningitis and sepsis. So the severity of pneumococcal disease ranges very widely, but it's especially dangerous in certain populations, such as adults over the age of 65, people with chronic health conditions, such as diabetes, people who are immunocompromised, and people who smoke cigarettes. Specifically in adults aged 65 years or older, 5% of these cases will die, and cases that progress to bacteremia and meningitis, the mortality rate is about 20% in those manifestations of disease. So looking specifically at New Mexico in comparison to the United States, I wanted to go over our surveillance system. So this is a pyramid of flu surveillance. At the bottom are the least severe cases, so asymptomatic, no illness, or those who are symptomatic but do not attend or do not seek medical care. We don't monitor those in our New Mexico surveillance systems. However, we do monitor outbreaks, and the majority of our outbreaks are in long-term care facilities. We monitor outpatient influenza-like illness through our Influenza-like Illness network. We also monitor lab-confirmed hospitalized cases, and that's our FluSurv NET network. And we monitor deaths. We work closely with the Office of the Medical Investigator and our Bureau of Vital Records to monitor any influenza or pneumonia-related deaths as indicated by ICD-10 code. And the purpose of our system is about fivefold. We surveil influenza to find out when and where activity is occurring, track these illnesses, determine which viruses are circulating and where, also to detect any changes in influenza viruses. So is it developing any resistance to our antiviral drugs, or are we detecting a novel influenza strain? We also use it to measure the impact influenza is having on hospitalizations and death. So our hospitalized influenza network, we are part of the FluSurv NET system, which comprises about 10 states. New Mexico contributes data from 7 counties, and we contribute the largest amount of data on rural populations and American Indian populations. Our network in New Mexico covers 60% of our population and 58% of our hospital beds. Our influenza-like illness outpatient network in New Mexico consists of 2 types of sites. So we have syndromic sites, where there's about 30 of them, and these are sites that are normally emergency departments, and they submit a standardized query of their percent of influenza-like illness each week. We also have what we call ILI-NET sites, and these are generally clinics, outpatient providers, urgent cares. They also send us data. So these sites send us data on the total number of patients seen for any reason each week, and then the number of patients within the total number that are for influenza-like illness each week. So that gives us the percent of outpatient visits for influenza-like illness. We also ask these sites to submit up to 5 unscreened swabs from influenza-like illness patients for subtyping each week, and we provide these equipment for testing free of charge. All of this data is combined to produce our weekly influenza report, which we put out to the public each week during our regular flu season. We publish it on our website, and this link will be included in the chat box in case you do want to visit it. And in this report, we report on geographic spread, any outbreaks, the percent of outpatient visits for influenza-like illness, lab activity, and flu-related hospitalizations and deaths. And this is the first page of our report, so you can look out for it. So this is a graph of our influenza-like activity over the past 5 seasons. And as you can see, every season looks a little bit different. There's one season with a very high peak, and there's one season with 2 peaks. So similar to what I was saying in terms of the differences in severity and transmissibility, every season's graph looks different. Looking specifically at 2017-18, this was a very severe season. So we peaked at 10% of outpatient visits for influenza-like illness during this season. This was a peak that was higher than the national average. And then in 2018-19, this graph looks very different. We had actually 2 peaks. The first peak was caused by H1N1 around the end of December into January. And then we were surprised by a second peak that was caused by H3N2. So this is a bit abnormal, as we usually only see 1 Influenza A subtype per season, but we did see a good distribution of both subtypes in the last season. This is a graph of hospitalization rates due to influenza, New Mexico compared to the US. As you can see, the rates of hospitalization are increasing over time, and that could be due to better testing practices, or it could be due to actual increases in disease. So New Mexico tracks fairly well with the US. Sometimes we're below, sometimes we're above. We didn't quite reach the national rate in 2017-18, even though it was more severe overall. But we did continue to increase in 2018-19 with a rate higher than the US average. And this is just those two seasons, 2017-18 and 2018-19, broken out by age groups compared to the US. I would like to point out the 0 to 4-year-old age group. New Mexico is the lighter blue and the green color, and our rates of hospitalization in this age group are much higher than the US rates. This is something we are looking into, whether it is due to the health status of our children or different admitting practices, but we are working with CDC to figure out why we are seeing rates that high in New Mexico. The other significant group is the over 65 age group. So while our rates are still high, they are below the US average. Now looking at flu vaccination coverage. This is for the entire population of New Mexico and the United States as recorded by the National Immunization Survey. So this is a population-based survey aimed to assess the overall vaccination coverage of the population. So New Mexico is historically a bit higher than the US. However, both New Mexico and the US have not reached the Healthy People 2020 goal of 70% vaccination coverage. So we as a country have a ways to go before reaching that goal. And this is just a geographical look at those same numbers. So New Mexico is kind of around the mid-range, a bit above the mid-range compared to other states in terms of vaccination coverage in populations able to receive the vaccine, so over 6 months of age. Looking at vaccination coverage specifically in healthcare workers, New Mexico is a bit below the rest of the US, but New Mexico and the US are both approaching that Healthy People 2020 goal of 90%. So we still have a bit of a ways to go, but and we could catch up to the US. So if any of you are responsible for that, we would love to increase our vaccination coverage in healthcare workers. And again, looking at this compared to other states, we are below the mid-range for that coverage. So we do have some work to do in that regard. And then looking at flu vaccination coverage in adult nursing home residents in New Mexico and the US, we are below the US in this goal. And the Healthy People goal there again is 90%. So both New Mexico and the US have a ways to go in that. And this again is something that we could use your help in. And then looking at the map for this, we are one of the lowest states in this, so we do have quite a ways to go in this regard. Looking at our vaccination coverage among hospitalized cases by season, the bars are the hospitalization rates in New Mexico. And like I said, 2017-18 was one of the most severe seasons, so our rate is higher. But looking at vaccination coverage, it ranges from 39% to almost 60% in hospitalized cases. And I would like to point out, obviously, this is a bit above our overall population vaccination coverage, and we do think this is due to a lower level of health for those that are hospitalized with influenza. Hospitalized cases often are those with comorbidities, so they may not have responded adequately to the vaccine, and they are also probably more likely to develop complications due to flu infection. Also, we do check multiple sources for history of vaccination coverage, whereas we believe the survey as well as our vaccination registry may underestimate the amount of vaccination coverage in the general population. Interestingly, there are major differences in vaccination coverage among different age groups and among different race and ethnicities. So this is just 2017-18, and as you can see, the age group of 65 years and older has a much higher vaccination coverage than any of the other age groups. So for all ages, vaccination coverage ranged from 53 to 61%, which is not a huge difference. But when you look at different age groups, the 0 to 4-year-old age group, American Indian children had vaccination coverage of 71%, whereas non-Hispanic white children had only 23% coverage. I would like to note that there were very small numbers of American Indian children hospitalized, so I would take that number with a grain of salt, as it's probably not representative of population coverage. Similarly, the opposite, in the adult population over 18, non-Hispanic white populations had almost 64% coverage, whereas American Indian adults had only 46% coverage. So this is pretty good information to know where we might need more targeted advertising or promotion of vaccines among different age groups and race ethnicities. Looking at vaccine efficacy over the past few seasons, since 2015 to 2018, the vaccine efficacy ranged from about 38% to 48%. However, in the 2018-19 season, that rate did drop to 29%. In mid-February, it was estimated at 47%, which would have been in the range of the past few seasons. However, that was right before the new H3N2 virus emerged. And so this was actually an unexpected clade, and a clade is an antigenically distinct virus that has a common ancestor. So it was still an H3N2 virus, but it was genetically different than the H3N2 virus that was included in the vaccine. So the vaccine we used last year was not very effective against this H3N2 clade, and that did drop the vaccine efficacy to 29%. The good news is this new clade was included in our vaccine for this coming season, so we're hoping for a higher vaccine efficacy going forward this season. We also track deaths due to pneumonia and influenza, like I said, and these are deaths reported to us from the Bureau of Vital Records, and they are deaths where pneumonia or influenza ICD-10 code was listed as a cause of death on the death certificate. We do report every pediatric influenza death to CDC, and we do a more in-depth investigation of that death. So why do we talk about influenza and pneumonia together? The most common viral cause of pneumonia is influenza, and it also makes a person more susceptible to bacterial pneumonia. Pneumonia can be present after it's too late to have lab evidence of pneumonia. So sometimes somebody develops a respiratory illness, but it's not serious enough to seek medical care. But later they develop a more serious case of pneumonia, and after that, it's too late to tell if they have had influenza. And this contributes to death certificates not explicitly mentioning influenza as a cause or contributing cause of death in patients who died of pneumonia. And this is why we monitor both pneumonia and influenza, because it is well known that influenza can precede pneumonia. So now I'd like to look specifically at our population of American Indians, Alaska Natives in New Mexico. Overall, pneumonia and influenza deaths have been decreasing in New Mexico and the United States. However, in New Mexico, we can see that one race ethnicity, American Indians and Alaska Natives, have much higher rates of death due to pneumonia and influenza than any other race or ethnicity. We can also look at it geographically. So this is a map of New Mexico by small area, and we look by small area because we have many rural areas and rural counties. So if we looked by county, the small areas of population could show us a different picture. So we do like to look at this by small areas, which goes by population rather than county lines. And we can see the darker colors mean higher rates of influenza and pneumonia deaths. And our concentration of darker colors is in the northwest corner of the state. And that is where the majority of our American Indian population resides. So we can see clearly here that that region of the state is disproportionately affected by pneumonia and influenza deaths than the rest. And just going back to vaccine coverage, adults are less likely to be covered by the, hospitalized American Indian adults are less likely to have had an influenza vaccine. I would like to point out, just in our FluSurv NET data, it's not clear that American Indians do have worse outcomes, so they're not dying at a higher rate. They are slightly more likely to be admitted to the ICU, but not significantly. And while they do have less coverage with the vaccine, they receive antiviral treatment at the same rate. However, when we look at underlying conditions, American Indians do have higher rates of underlying conditions than other race ethnicities. So higher rates of diabetes, alcohol, liver disease, renal disease, and obesity in our FluSurv NET data. So takeaways, American Indians, Alaska Natives have higher rates of death due to influenza and pneumonia than other race ethnicities as measured by our Bureau of Vital Record. They also have higher percentage of underlying conditions, but may not have worse health outcomes according to our hospitalized data. Of course, this does not capture everything that happens in the community. It only captures what happens in the hospital. And again, American Indian children ages 4 and under in the 2017-18 season were vaccinated above the state average, while adults were vaccinated below. And now I will turn it over to Emma to talk to you about nosocomial transmission.
All right, so hello everyone, this is Emma Stanislavski. So I'm going to start with just a study that was done in Canadian hospitals from 2006 through 2012. This was an analysis of almost 3,300 hospitalized adults who were hospitalized for flu. This study defined healthcare-associated influenza as illness onset occurring at least 96 hours after admission. So this is the maximum incubation period for flu, so they could be absolutely certain that these cases definitely caught flu while they were in a healthcare setting. And they found that 17% of their cases were healthcare associated. Of those, about 60% were acquired in a long-term care facility, and the remaining 40% were acquired in an acute care facility. So the reason I bring this up is because hospitalized patients are more likely than the general population to be at high risk for severe disease or death from getting the flu. And immunocompromised patients have longer viral shedding periods, and so they need to be treated for longer periods of time, which gives the virus a better opportunity to develop resistance to those antivirals, which we definitely do not want to encourage. This was another study of a nosocomial outbreak of flu in an oncology unit that was related to healthcare worker presenteeism. So we know that many healthcare workers feel obligated to work while they're sick. In this particular outbreak, there were 23 cases, 16 of which were healthcare workers, and also 7 out of the 10 patients on the oncology ward. 64% of the healthcare workers attended work while they were sick. Of those that did so, they said that 56% cited a sense of duty as a healthcare worker, and 44% viewed their illness as too mild to really pose a risk to others. The cost of prophylactic oseltamivir for 108 people and treatment for the 23 people involved in the outbreak added up to almost $10,000. This was another study in a hospital that implemented stronger healthcare worker vaccination mandates, and they found that as their healthcare worker vaccination rates went up, their proportion of nosocomial flu infections went down to the same degree over several seasons. This is a study that just came out about a month ago. This was an anonymous survey done at a series of University of Iowa hospitals and clinics, where they were asking medical students, residents, and faculty about their attitudes related to working while sick. And they found that the residents were by far the most likely to feel obligated to come into work while sick. This included even if they had flu-like symptoms such as fever, myalgias, and cough. Over 2/3 of residents said that they would still come into work. And even if they had a fever of greater than 101.5, still over 1/3 of residents said that they would still come into work while sick. This is compared to a much smaller proportion of students and even smaller in faculty. When they were asked why they would do so, students and residents reported similar reasons. They feel so much pressure to avoid creating more work for their coworkers, to avoid negative repercussions, and to avoid being seen as lazy or weak, that they feel obligated to come into work, even though they are recognized as seeing reasons why it's important to stay home when they're sick in order to protect their patients. So this really emphasizes why it's important to recognize that students and residents, they're already under so much pressure to prove themselves, that it's important to foster a work culture where they do feel comfortable staying home when they're sick in order to protect those patients. So there are several ways to prevent nosocomial infections. The first is obviously vaccination. We want to ensure that all patient care staff and long-term care residents are vaccinated. We would like all patients, visitors, and staff with respiratory symptoms to wear a mask, as well as all unvaccinated patient care staff for the duration of the flu season, and all staff, whether they are vaccinated or not, who are within 6 feet of a suspected flu patient. If you have a healthcare worker who is sick, we would like you to exclude them from patient care for at least 5 days after their illness onset, and they should also be afebrile for at least 24 hours without antipyretics, and they should have improved symptoms. And when it comes to your patients with flu, we would like you to keep them in private rooms on standard and droplet precautions for 7 days after illness onset, or again after they are afebrile for at least 24 hours without antipyretics, and again improve symptoms, whichever is longer. So now I'll move on to preventing illness and death using vaccination, antivirals, and social distancing. So we all know that the injected or inactivated flu vaccine is recommended to everyone over 6 months of age. There are a couple contraindications. For example, if you have a history of severe allergic reaction to a prior flu vaccine or to a component of the vaccine. This did not include eggs. People with egg allergies still can and should receive flu vaccine every year. And there are a couple precautions. If you have a patient with moderate or severe acute illness, you may want to hold off a little bit until they recover to give them their flu vaccine. And if your patient has a history of Guillain-Barré syndrome within 6 weeks of a previous dose of flu vaccine, you will want to discuss the risk and benefits of getting that vaccine. But it's important to remember that Guillain-Barré syndrome is much more likely to occur after getting an actual flu infection than after getting the flu vaccine. The other option is the live attenuated nasal spray vaccine. Because it's live attenuated, it does have several more contraindications and should not be given to immunosuppressed people or pregnant individuals. It is also only approved for people who are ages 2 to 49 years old. Last season, the American Academy of Pediatrics preferentially recommended the injectable or inactivated vaccine because of concerns over the effectiveness of the nasal spray vaccine. However, with the new data that they have seen in effectiveness from this past season, they do not have a preference this coming season. So if you have a patient that refuses to get the injectable vaccine, it's fine to give them the nasal spray, assuming that they are otherwise eligible for it. So we know that everyone over 6 months old should get a flu vaccine, but it is especially important for certain high-risk groups. These include all children under age 5, but especially those under age 2, all adults age 50 years and older, pregnant women and women who are planning to become pregnant during that flu season, American Indians and Alaska Natives, people with chronic conditions such as those listed here, people who are morbidly obese or have a BMI greater or equal than 40, people who are immunocompromised for any reason, children aged 6 months to 18 years old who are receiving aspirin or salicylate-containing medications, residents of long-term care facilities and or nursing homes, household contacts and caregivers of any of the above, and finally, healthcare personnel. But it is a lot easier to just remember this part and vaccinate everyone over 6 months old. However, the reason that we especially prioritize those groups, for example, if you have a patient with diabetes, they are at elevated risk of pneumonia and secondary bacterial infections if they get the flu. Flu can actually affect their blood sugar control, and a flu shot is associated with a 79% reduction in flu hospitalizations in people with diabetes. Pregnancy causes changes in the immune system, heart, and lungs that make pregnant women and those who are less than 2 weeks postpartum more prone to severe illness from flu and at higher risk for hospitalization. The flu shot during pregnancy reduces the risk of hospitalization for flu by 40%, and as an added benefit, also provides maternal antibodies to the newborn baby, who, remember, cannot receive a flu vaccine until they are 6 months old. People with asthma or COPD are at risk for more asthma attacks or worsening of symptoms if they catch the flu. And people with asthma are also more likely to get pneumonia after flu than people without asthma. And people who are age 65 years and older account for the majority of our seasonal flu deaths and the majority of our flu-related hospitalizations every flu season. So the 2019-2020 flu vaccine composition: if you get the trivalent vaccine, you will get an H1N1 A strain, an H3N2 A strain, and a Victoria lineage B strain. If you get the quadrivalent vaccine, you'll get all three of those above, as well as an additional Yamagata lineage B strain. The World Health Organization, or WHO, makes the decisions about what goes into each season's flu vaccine every February. However, this year they delayed their decision on what the H3N2 component would be. So they made their decisions about H1N1 and B, but at that time there were multiple H3N2 virus groups co-circulating. There was a distinct group of the 3C3A clade of H3N2 viruses that Chelsea mentioned earlier that was rapidly emerging and increasing around the world, including here in the United States. So the WHO decided to wait a little bit and see how the situation panned out. And they eventually decided to switch to that new clade as part of the H3N2 component in this coming season's vaccine. H3N2 is especially prone to egg changes, or adaptations while it's growing in eggs during a vaccine development process. This isn't just H3N2, but it is especially susceptible. And this is where the vaccine virus that you put in the egg to grow it mutates just enough that when it comes out, it is a little bit different than a vaccine virus that you intended to get. And that can affect vaccine efficacy. There's currently some efforts going on, including a recent executive order from the White House, to transition away from egg-based vaccine processing and move into more recombinant or cell culture-based vaccines and other next-generation flu vaccine technology for future seasons. I've included a couple of frequently asked questions from the Immunization Action Coalition. So when should you administer flu vaccine? Ideally before the onset of flu activity in the community. And remember that it takes about 2 weeks for the flu vaccine to take effect. So it is okay to give your patients flu vaccine starting now, and it is best if they receive it before Halloween. If you have a patient that shows up in March and they still haven't been vaccinated, you can still give them vaccine, even if they've already caught the flu, because they could still be susceptible to another strain. But really continue giving flu vaccine as long as you still have unexpired vaccine in your office. Sometimes you have a patient over 65 years of age who already received a standard dose flu vaccine, and they hear about the high dose and they want that one in addition. So some people have asked if that's okay to give them the 2 doses. Please do not. ACIP does not recommend that anybody receive more than 1 dose of flu vaccine in a given season. The only exception is for children aged 6 months to 8 years, where if it's their first time ever getting a flu vaccine, they should get 2 doses. But if you have a patient that has a standard dose and they want to get this high dose in addition, that is not recommended. And does ACIP preferentially recommend the use of high dose vaccine for people aged 65 years and older? You might think so, but no. Although there is evidence that the high dose vaccine has better efficacy in that age group compared to standard dose vaccine, ACIP has not made a preferential recommendation for high dose vaccine because they believe it's more important that that age group just get any flu vaccine at all. If it's high dose, that's great. If all they have is standard dose, they should still absolutely get it. Now we're going to move on to pneumococcal vaccines. There are 2 types of pneumococcal vaccines. The first one is PCV13, or pneumococcal conjugate vaccine. This is recommended for infants, young children, and as of 2019, as part of a shared clinical decision for adults aged 65 years and older. And this vaccine protects against 13 kinds of pneumococcal bacteria. The second kind is the pneumococcal polysaccharide vaccine. This is recommended for adults over 65 years of age and protects against 23 kinds of pneumococcal bacteria. However, both of these vaccines are also recommended for adults aged 2 to 64 years with certain medical conditions. The ACIP recently voted this summer on updating the pneumococcal vaccine recommendations. So there is no change to the polysaccharide vaccine. All adults aged 65 years and older should continue to receive it. However, instead of the normal routine recommendation, ACIP now recommends that PCV13 be given based on a shared clinical decision between a patient and a provider for adults aged 65 years and older who do not have an immunocompromising condition and who have not previously received a dose of PCV13. The reason for this is that there is such a benefit and reduction in disease from giving the PCV13 vaccine to younger children that there was not as much benefit in giving the PCV13 vaccine to the older adults themselves because they were reaping the benefits of the children getting vaccinated. However, as of September 2019, CDC has not yet updated their website with these updated recommendations. So if you have a patient aged 65 years and older and you're giving them both types of pneumococcal vaccines, they should receive PCV13 first, and it should be at least a year before the polysaccharide vaccine. It doesn't need to be exactly 1 year, but we say that because Medicare will generally only cover both vaccines if they're given at least 11 months apart. If you have an adult with a high-risk condition, you don't need to wait a whole year. You just need to give the two vaccines at least 8 weeks apart. So this is kind of a summary of the pneumococcal vaccines. If you have children who are greater than 2 months old, they should get a 4-dose series of PCV13 at 2, 4, and 6 months, and then a booster dose at 12 to 15 months. The old recommendation was a routine recommendation of PCV13 dose for adults aged 65 years and older, and a year later that polysaccharide vaccine, 1 dose. However, the new recommendation is that the PCV13 dose be given as part of a shared clinical decision between a patient and the provider, weighing the cost and benefits, but still giving that vaccine first, and then a year later the polysaccharide vaccine, still 1 dose. If you have an adult with immunocompromising conditions, functional or anatomic asplenia, or other chronic conditions and risk factors, you may need to shorten the interval between those 2 vaccines from 1 year to 8 weeks. Your patient may need 2 doses of polysaccharide vaccine separated by 5 years. And these recommendations can get very complicated, so we have a couple of guides on the next slides. This first table is available from the Immunization Action Coalition, and the link is on the top right and will also be available on our final contact slide if you need time to write it down. But this breaks your patients down into immunocompetent, immunocompromised, and nosofunctional or anatomic asplenia, and has a nice breakdown of exactly what underlying conditions you need to consider and for which vaccines and whether that affects the intervals or the number of doses that they need to receive. This is a similar table with about the same information, but just presented in a different way that you may find more helpful. This is available from CDC. Again, the link is at the top and will also be available at the end if you need time to write it down. I wish I could just give you a 1-sentence recommendation to make pneumococcal vaccine recommendations very easy, but this is unfortunately the best I have for you. All right, so now we're going to move on to antivirals and other strategies for preventing illness and death. So early antiviral treatment, which is ideally within 2 days of illness onset, has been shown to shorten the duration of fever and symptoms and reduce the risk of complications such as pneumonia and respiratory failure. So antiviral treatment is recommended as early as possible for any patient with suspected influenza who is hospitalized, has severe or complicated illness, or is at higher risk for influenza complications, which we went over that category of patients earlier. There are 6 licensed flu antiviral drugs approved in the United States. As Chelsea mentioned earlier, half of these are neuraminidase inhibitors. This is a nice table available again from CDC that just goes over the age recommendations, side effects, and other contraindications that you may need to keep in mind. We do have antiviral treatment data from our FluSurv NET network. So from the past few flu seasons, patients hospitalized with flu who received antiviral treatment has been steadily going up. However, the proportion of those patients who received antivirals within 2 days of illness onset has remained stagnant. So this is definitely an area that we can improve upon in the coming season. And again, this is very simple but effective, just keeping signage and other visual alerts around in common areas, reminding people about cough etiquette and hand hygiene. And don't forget about environmental cleaning. So in addition to your normal disinfection of exam rooms and sterile surfaces, Don't forget about doors and doorknobs, stair railings, elevator buttons, and any other commonly touched surfaces in public areas in your facility. And encourage hand hygiene by keeping your hand sanitizer stations and sinks well stocked with soap and paper towels. We would like to thank Margaret Cunningham of the New Mexico Department of Health Immunization Program for her help in creating this presentation. If you need to report a flu outbreak, flu-associated pediatric death, or your lab finds a novel influenza strain, please call our 24/7, 365 Epi-on call line at the number here. If you would like to be added to the weekly New Mexico flu report distribution list, please just send me an email at my address there. And as I mentioned before, those two pneumococcal vaccine guides, the links are right there. And I'll leave this slide on for a little bit so you have time to write it down. But we are going to transition into the Q&A period.
Thank you so much, Chelsea and Emma. That was really amazing information. We do have time to have some questions. And if you have not had a chance, you can write your question in the chat box. We've received quite a number of questions already. So just to let you know, if we don't get to your question, we will be answering it in an email format for the group. So the first question is that I've heard people this year are having severe adverse reactions to the flu vaccine. Have you seen this?
So the rate of adverse reaction to flu vaccine isn't expected to be any different than that for other vaccines. The most common one that we see is SIRVA, which is a shoulder injury that is a result of administering the vaccine incorrectly. But I am not aware of any other unusual rates of severe adverse events in flu vaccines.
And if you do see any of those, you should report them to the VAERS system, the Vaccine Adverse Reaction. Sorry, you probably know it better.
The Vaccine Adverse Event, I believe, Response System, which you can report that online, either as a healthcare provider or as a citizen.
Thank you. So here's another question. Has there been any discussion of mandating flu vaccine for healthcare workers from the state level? This would make it easier to achieve the goal of 90% if we remove the option for healthcare workers to decline when vaccination is not medically contraindicated.
So currently I'm not aware of any mandates like that happening at the state level, but we are definitely dependent on healthcare setting level policies where you can make those mandates yourself.
We do have a mandate that hospitals are required to offer vaccination to anybody over the age of 65 upon discharge. They're required to offer vaccination at that point. But as far as I know, that's the only mandate we have in the state.
Great, thank you. So here was a comment. Several Indian Health Service areas in the country achieved the Healthy People 2020 goal of 90% or higher influenza vaccine coverage among healthcare providers in federal IHS facilities. Specifically in the Albuquerque IHS area for flu season 2017-18, the rate was 90%. And last year in 2018-19, the rate was 96%. They wanted to share that information. Here's another question. I've heard talk of the possibility of a second flu shot being developed because this year's flu strain has changed early in the season. Do you have any information on that?
That would be the first that we've heard of that information. As far as we know, there is still only the one flu vaccine recommendation as we've seen in prior flu seasons.
Yeah, we haven't actually had any flu yet really in New Mexico to speak of. Okay, here's another question. What makes hospitals and group home patients at a high risk as a high-risk population versus those who are in jail or prison? Any data on influenza-like illness in jails or prisons?
Sure, so both of those contexts all residents or people who are in institutions are in kind of close contact with each other on a day-to-day basis. So both of those situations do make it more likely for flu to rapidly spread among residents. However, in long-term care facilities, the residents are usually those more susceptible to complications. So those over the age of 65, those with comorbidities, whereas populations in prisons and jails are more likely to be a younger, healthier population. We do monitor outbreaks in correctional facilities, and if we get a call about an outbreak, we will help the facility implement control strategies, get testing done, and hopefully prevent the further spread of that outbreak. And our response to long-term care facilities as well as correctional facilities is very similar. We implement or we recommend the same control strategies in both scenarios. We do not receive routine information about influenza in correctional facilities.
Great, thank you. So here's another question about sort of that shift in the H3N2 that you'd mentioned. What's the recommendation for patients who were vaccinated earlier this year with the influenza vaccine before they came out with the reformulated vaccine? I have providers asking if they should be revaccinated when the reformulated vaccine is available.
So any vaccine that is available currently for this coming season is the reformulated vaccine. So as long as you're not administering the vaccine from the previous season, you should be fine. And we would recommend only vaccinating with the reformulated vaccine. In some private pharmacy clinics, that was available at the end of August through September. And as far as we know, a lot of clinics and healthcare providers are just getting their orders of vaccine for this season. So as long as you're not administering the one from last season, you should be fine.
Okay, great. And that is part of the reason why we have a new flu vaccine every year, because the strains do shift. We've had a couple of comments about the slides, and yes, they will be made available once we have this on the website. And so all participants will be receiving an email with how to get those slides. Here's another question. What's the difference between the PCV7 and the PCV13? I'm a school nurse, and while these are not currently required for students, I'm wondering if protection is relatively equal, or if children vaccinated with PCV7 need to get any additional boosters.
So the PCV7 would only protect against 7 pneumococcal bacteria types, whereas PCV13 would protect against 13 types. The PCV13 is the one that is recommended as a routine vaccination series in children who are older than 2 months old.
And the PCV13 has been available for a lot of years now, so there hasn't been PCV7 for quite a number of years. Okay, here's another question. Some people like to wait until later in the season, after October, to get their vaccine and to assure that it lasts for the whole season and that it's strong at the peak of the season. Can you comment on that?
You're definitely taking a risk by taking that strategy. We don't know if this season is going to have an early peak. And so the longer you delay your flu vaccine, the longer that you're going to be susceptible to flu. We know that the flu vaccine lasts for at least 6 months before it starts to wane, but it's best to get it before October so that you are covered for the majority of where we see our peaks every flu season. So if you can get it before Halloween, please do so.
Great. Okay, well, I think we're coming to the end of our hour. Thank you so much, Chelsea and Emma. This was an amazingly informative webinar. Thank you for your participation on the Zoom, everybody out there. If you are looking for CME credits, there's information on the slide on how to do that. There's a link that you'll have to go to, and this link will be available for 30 days following this live event. And if you have any questions that we didn't get to, please continue to put them in the chat box, and we will have our presenters look at those and respond after the fact. Thank you so much. Enjoy your afternoon.